Today I will be very happy to go through some few steps of the clotting screening and relate them to how we can understand the special coagulation test. Most often we come across questions like, do you have any understanding about the special coagulation test? And because we have been reconstituting reagents and putting them on the analyzer, it sounds like, but there are more into it that will really furnish the understanding of the clotting screening and how the analyzer relate to it, and how manufacturers kind of mimic the knowledge within the natural process of clotting formation or primary hemostasis within the body, and the way they're able to produce reagents that are able to elicit an in vitro clotting process on the analyzer. Just to begin with this simple flow chart on my left side, most often we come across clinical details like thromboembolism, DVT most common, PE or pulmonary embolism, and especially shortness of breath comes up in the clinical details when you're authorizing the coagulation test. But how do you relate them to the results that you are seeing on your screen? You can't afford to miss this one as a specialist scientist, and therefore I take this as an opportunity to explain them. So just to begin and refresh our minds on clotting screening, let's pick up this. What is thromboembolism? Thromboembolism is the formation of a clot in the body, and deep vein thrombosis is when a portion of this clot form dislodges into our leg veins or leg blood vessels. Sometimes within the pelvis can also occur. This is what we call deep vein thrombosis, and it can come with pains within the legs, redness of the leg, changes of color different from the other leg. On pulmonary embolism, on the other hand, when a portion of this clot formed, whether in the deep vein or wherever it is, dislodges and is carried along within blood into our lungs, where you go our pulmonary arteries and pulmonary veins. When it dislodges there, it is very painful. It comes up with a shortness of breath, chest pain, cough, and redness. And these are as a result of a hypercoagulable state. When you say a hypercoagulable state, any state of a patient that predisposes them to clot formation. For instance, if you've undergone a major surgery, you are prone to that. If you've been bedridden for very long, you are predisposed to that. People with cancer, some state of obesity as well can also lead to hypercoagulable states. And the last thing I would say is people who are on hormonal treatment. It can also lead to that, but in your best state, anything can be related to that by contacting the right source to do the right test. Coming back to the most important thing of our discussion, this was just, by the way, for remembrance of the relevance of what we are coming to do. But the most important one is how the natural primary hemostasis or clot formation in the body has been transferred into an in vitro mechanism of testing on the coagulation analyzers. If you look at these are the anatomical structures of our veins and arteries. This is the artery, and this is our vein. And looking at the anatomical structures of these two, they look quite similar. So when you go into this lumen, you'll find out that because veins carry blood back into the heart, so just quite upward, they've got valves or cusps that prevent backflow of blood, which is not part of this discussion. The most relevant one you should pay attention to is the presence of this collagen within the tunica externa. And as well, in the smooth muscle, there will definitely be a tissue factor, which is the factor 3 tissue factor present in here. And these two play a vital role in the primary hemostasis of the body during an injury or a trauma. These are involved in the primary one, and this is the same strategy manufacturers use in producing reagents for a test and the mechanisms that will be used on the analyzer as well. Therefore, let's rush down here to my next slide, which I have grouped all these coagulation factors into major groups like this: fibrinogen group, I've got the prothrombin group, I've got this contact group, and finally I have stick something here and remove my image as a collagen here. We've made mention of collagen in just the past slide. I'll not go back there again. Let's go forward here. Look at it. It looks like a flow chart, and it makes sense in understanding coagulation factors. Let's have a move. Let me change this pen into red. The flow will be that in the body for a primary hemostasis, when there is an injury in the blood vessels, the collagen will be exposed. And other injuries can also expose tissue factors, which I'll go into that in a second. So starting with this collagen exposed will now activate all these contact factors. Mentioning them, we've got the factor 12, prekallikrein, high molecular weight kininogen. These are all the contact factors. Now we move forward. When contact factors are activated, in the next move, forming clot in the body, the contact factors go ahead to activate the prothrombin group here. And this prothrombin group, when they are activated, in the presence of calcium, that is Ca2+, they are activated to undergo the cascade into the common pathway, and then finally a clot formation. And let me quickly mention it here that though we have this factor 7 within this prothrombin group, and looking at this in this collagen to contact factor to prothrombin, this will be exempted. Factor 7 is not activated by collagen, it's activated by tissue factor, which is factor 3, and it's within the extrinsic pathway. Just to clear it out on that, not to confuse. The one second aspect you should know is that even as we have seen this flow of collagen to contact factor to prothrombin group in the presence of calcium, and then keep in mind that calcium is required in the activated state of all these factors. So if you want to know where calcium is involved in the coagulation cascade, it's common to note that when you see activated factor 2, there should be a calcium. Activated factor 7, there should be calcium. Factor 9, there should be, and then activated factor 10, there should be a calcium. And finally, this factor 2, when it is activated, it is called thrombin. So this is prothrombin, this is proconvertin, this is Christmas disease, that's factor 9, and then Stuart factor is factor 10. Yeah, I remember. Okay, so I will circle this factor 2 just to make reference to its activated importance in reference to the fibrinogen group. Now, thrombin activates fibrinogen group. So at the moment, it is not all the prothrombin group going to activate the fibrinogen group, but it is just thrombin that is able to activate all these fibrinogen group. So if you want to remember fibrinogen group, we also call them all factors that thrombin activates. That makes a bit of sense. Let me bring you back to prothrombin group, where calcium is a champion cofactor. I've written down here they depend on vitamin K, and they are also inhibited by warfarin. I think you can read that, but let me have a quick flash through on why they depend on vitamin K. So the most important thing that we should look at is where this glutamic acid residue is found. These are found on the coagulation factors, and therefore when it undergoes this carboxylation by gamma glutama carboxylase, it gains a new structure. This GLA is called the gamma carboxyglutamate. This makes that coagulation factor active. So this residue is found on the coagulation factors. By the carboxylation process, they become this structure, which is the active form of the coagulation factors. So there are two stages of vitamin K that you should understand. We call vitamin K epoxide, this is the inactive stage, and then vitamin K hydroquinone, which is the active stage. Now, in the body's own metabolic state, where glutamic acid has to be activated by gaining a hydroxyl group. If you look here, there's only one hydroxyl group. In a carboxylation process, it gains an extra hydroxyl group that makes this glutamic acid potent for its activity, and this is just one side chain, a methyl group on this glutamic acid. Those who love amino acid metabolism, you understand it very well. And the most important thing is here, when hydroquinone, vitamin K, which is the potent state, enhances the carboxylation of this amino acid, it now gets carbon dioxide added to its structure, which makes it an epoxide, inactive vitamin K. It has to be reconverted back into its potent state by an enzyme called vitamin K epoxide reductase. This is what I've written down here. This is how warfarin will come a longer way to inhibit this enzyme making it unable to convert the inactive vitamin K into active state, and therefore all these prothrombin group which requires vitamin K for them to be activated will now remain in blood, not being activated because there is no vitamin K. So in a case of overdose of warfarin, to reverse it, sometimes they prescribe you being given vitamin K as a supplement to solicit for the inhibited vitamin K here from coming back to active state. Let's rush back to where we want to go. Now, warfarin, you understand how warfarin works. That's really good then. It's good we've got good idea about this part of warfarin inhibition and all that. But not lagging this side behind, we have fibrinogen group, which I've talked about that it is only thrombin that activates these coagulation factors. And I've written down here depends on thrombin, and they are inhibited by heparin. Let's look at it. What does heparin do? Remember that the body has its own anticoagulant. So when they fail, we give synthetic ones to them in the form of a dose. For instance, this heparin, this warfarin, they are all anticoagulant, trying to play the role of the failed natural anticoagulant. What are the natural anticoagulants? You have protein S, protein C, antithrombin 3, activated protein C that we do test in thrombophilia screening. These are all natural anticoagulants. Now, if it is a natural anticoagulant as antithrombin 3, it is available in blood. Heparin cleaves antithrombin 3 and makes it active. Antithrombin means it's against thrombin. So in the presence of heparin, antithrombin 3, AT3, is activated. It's going to bind to this thrombin, and therefore it is not going towards elicit its effect of activating these clotting factors. So these clotting factors will be available, but they will not undergo a clotting cascade because their activator has been gripped by an antithrombin because of heparin. This is very interesting when we get to the next slide, which is the main reason I made this video, and it is the clotting cascade. So I've launched the clotting cascade here, but for us to do a transferable studies from the preceding slide into this slide, I'll mark some vantage points for easy understanding of this coagulation cascade. I will go for a color, and I'll pick a color yellow for the center of the coagulation cascade, which is activated factor 10. Now, I'll make a bigger circle around all these factors that thrombin activate. Now, I make this bigger circle. Yes, I have finished with this bigger circle. And now I go for a red color and I circle their major centered activator, which is thrombin. So I spoke to you that under this group, it is only thrombin that activates all of them. Let's see in the cascade if it is true. Now, thrombin going this way, activating factor 13, number 1. Now we've seen thrombin going this way, converting fibrinogen to fibrin. Now we've seen this is true. Now we've seen thrombin going upward here, activating factor 5 and 8. Now we do this way. So when we come back to this, now we've covered up. Now you understand why the common pathway is called TT, thrombin test, because they all depend on thrombin. We've cut one section of the coagulation cascade out in a meaningful way. So this factor 5 and 8 that thrombin activated, they have been placed here. One of them is factor 5. It is lying here because it is not under the cascade. It is on its own, activated by thrombin. Now I have another circle to mark, which is factor 8, activated by thrombin. It is not true down here on the cascade. It is on its own because it is thrombin that activated it. Great. Now we can look at these sides, that all the sides that will come up here on my left side is the extrinsic pathway, and we study it under the PT test, giving us an INR. And then on my far right side, I have circled all of them down here, and that is the intrinsic pathway. We study them under the APTT test. Let's go on one after the other. Coming on the extrinsic pathway, which involves tissue factors in the PT test, we have when there is an injury within the blood vessels, the smooth muscles in there contain tissue factor, and this tissue factor, which is also known as factor 3, is what is required for us to activate factor 7. And then from factor 7 we get activated factor 7, and then activated factor 7 will act on factor 10, getting us into the common pathway. Before we go on to the intrinsic pathway, let's look at what happens here that make it sensible for manufacturers to perform the PT test using the reagents that we have. The common thing initiating this cascade is tissue factor. Now, how do we get a tissue factor? They extract a tissue from rabbit brain, and we call it rabbit cerebral tissue, which is called thromboplastin. So in the neoplastin reagent, the lyophilized powder contain this tissue factor from rabbit. So the rabbit thromboplastin is what is going to replace this tissue factor from our body in the PT test. Have you finished? No, we still need calcium. So if you are not careful, you will think that the neoplastin reagent and the PT test doesn't require calcium. It is not true. The neoplastin reagent has the lyophilized plus a liquid, which is I think 5 ml or 10 ml, that we add and reconstitute to the powder. Leave it for 15 to 30 minutes before we load on the analyzer. That liquid contains a 0.025 molar of calcium. Unlike the APTT test that you find the calcium chloride separate or written on it observable, that's a liquid that we use to reconstitute neoplastin reagent contain a calcium. So don't forget it, because factor 7 here on my previous video, on my previous slide, factor 7 is here. It requires calcium, so it's definitely going to need calcium. So don't forget this aspect. So the PT test is sorted out with a thromboplastin within the reagent. That is how you're going to obtain the PT results, and then we deduce the INR from it. And just a cover, the INR is the international normal ratio. We obtain it from the PT over the average of normal PT samples. So you got about, let me say, 20 samples, you run PT on them, you take the mean average of them, and that is the PT normal or the reference. So the patient results for INR will now be the patient's PT results over the PT of the normal samples that you run. That is the average of them, the mean, and then all of them exponent the international standardized index. So that will come with the reagent, and you will see on it that the leaflet will give you the international standardization index, and that is how you obtain the INR from PT results. You can read more about it. We don't have much time on that. Rushing back to the intrinsic pathway, let's look at this one. In the intrinsic pathway, unlike this that require tissue factor, I told you from this side that you need collagen in the body to initiate the activation of contact factors onto prothrombin, which is within the intrinsic pathway. This intrinsic pathway. But now we don't have collagen in the patient's sample because there is no injury. So we need something that can mimic the effect of collagen in the APTT test. Now the manufacturers thought that phospholipid and silica have the same effect as collagen, and therefore the APTT reagent 1 contains phospholipid and or silica, which is able to perform the function of collagen, now activating the contact factors. And then when you talk about the contact factors, don't forget that we have factor 12 here. Going back to our video, you see the contact factor has factor 12, prekallikrein, high molecular weight kininogen. Quickly, let's go back. Now you've got factor 12 activated because of what? The phospholipid and silica in the reagent, performing the role of collagen. Factor 12 activated, come to factor 11 activated. Here, then we need calcium, come down and activate factor 9. So it's like from 12 to 11 to 9. And then activated factor 9 will now also need calcium, and then comes down to activate factor 10. Back into the common pathway. So this is basically all the clotting cascade and how they relate to the test that we do in-house, and then what is in the reagent that is going to replace the natural collagens and then the tissue factors to make the analyzer work. They would need incubation definitely, just to make sure the in vitro activity is under 37 degrees, which is the assumed or the likely temperature of almost every normal person. Incubation will be done, calcium will be replaced in the various coagulation processes, and then the time from which calcium is added to the time that a solid mass will be formed, where the ball within the cuvette, that solid ball within the cuvette, can no more move, will be the PT time or the APTT time, and that will be converted into seconds, and that will be relatively juxtaposed to the normal graph you've got on the analyzer, and it gives a value for you to use in your reporting. I believe this helped. The next two are just an idea about the APTT reagent and all that. So the only thing I'm going to mention again would be the enzymatic effect of factors. A couple of times people have heard this, but it sounds different or quite difficult to grab, but that's not the case. It's just a matter of understanding this. And I'll pick a red line, and I'll circle this 10S complex and that of prothrombinase complex. I will undo that. Sounds weird, or circle it properly. Yes, so if you look at the end of each of them, you see ASE, which is ACE. And in science, ACE means an enzyme. So when we say 10ACE, is any group of factors like factor 9, activated factor 9 and factor 8 that is able to activate factor 10, that is 10ACE. And any group of factors like activated factor 10 and factor 5 that is able to convert prothrombin to thrombin is what we say prothrombin ACE. So it is a prothrombin enzyme that converts prothrombin to thrombin. So if you go back to this slide, we can just judge it from here, because we know that it is thrombin that activated both factor 5 and factor 8, and we got factor 5 here whilst factor 8 is here. And if you look at this slide really carefully, you can see that before we got factor 10A, that's activated factor 10A, it is a couple of factors that join hands together, that is factor 9 and factor 8, that join hands together to activate factor 10 in the intrinsic pathway into activated factor 10. The same way we can also say in the extrinsic pathway, 7A is also a 10ACE because it's able to convert factor 10 into activated form. And looking at this prothrombin, what is its ACE? A group of factors from here, factor 10 and factor 5 together in an activated form, come straight down here to convert prothrombin here to thrombin. So when you are talking about prothrombin ACE, is this group of factors, factor 10A and 5A, which join hands to convert prothrombin to thrombin. And when we say factor 10 ACE, is this factor 9 and 8 here, which join hands to convert factor 10 to its activated form. Or in the extrinsic pathway, factor 7, converting factor 9 into factor 10. Okay. We will close here. I believe this is quite a long talk, but it's worth it. It has made a lot of sense and clarity on the clotting factors. And in my subsequent videos that I will launch into the special coagulation test, you will find it so easy if you master these basics. If you love this video and it's quite educative to you, you may like to press the like button, subscribe or follow this channel, and share or comment. Put any arguments or what you think you've got from this video, or anything that you may need further clarity. We will discuss it and see how best it will sound in our ears. Thank you for watching this video. Have a nice day.